We're going to continue talking about the cardiovascular system, and in the previous lecture we talked about the major determinants of cardiac function being preload, afterload, and contractility. And in this lecture we're going to focus primarily on preload, which by definition is the left ventricular end diastolic volume, or it can be thought of conceptually as a stretch within the left ventricle during diastole, or the relaxation period within the cardiac cycle. And it has to do with the stretch of the myofibrils within the ventricular wall, or the actin and myosin filaments. The actin filament and the myosin head, the stretch between these two, which acts as almost like a rubber band effect, and the elastic recoiling effect that affects the cardiac output. And we can show this and illustrate this correlation with the Frank-Starling curve, in which it shows on the x-axis the preload, which is the left ventricular end diastolic volume, and on the y-axis you have the cardiac output. And if you were to illustrate a normal, healthy heart at rest, you can show that as you increase the preload, it has a correlating increased cardiac output to a certain extent. And this shows that when you have optimal preload or optimal volume within the left ventricle during diastole, or at the end of diastole, you have an optimal cardiac output as far as a correlation. And very quickly we can say that if you take the same healthy heart and now you ask the patient to exercise, you can see that there's an increased cardiac output. Although the preload is roughly the same, you have a sympathetic tone, an increased sympathetic tone that helps to increase the cardiac output with increased contractility and increased heart rate. Likewise, if you had a heart that was in failure, for example, congestive heart failure, you can see that you have a decreased cardiac output. And even further, if you have a patient that's in cardiogenic shock, you can see that you have an even further worsening cardiac output at the same correlating preload. So now if we were to look at preload and focus on preload, we can say that preload is the left ventricular end diastolic volume. Now if we just focus on the left ventricle and we show three clinical correlations of the left ventricle, for example, looking at the same patient but three clinical differences. For example, if you had one patient, the same patient, hypovolemic or under-resuscitated as far as fluid, or if you have the same patient in which you have optimal or adequate volume within the left ventricle during diastole, or as a third example, have the same patient in which you overload the patient with fluid in the left ventricle and now becomes hypervolemic. We'll start off in the hypovolemic state, in which there's a decreased preload and there's an understretch of the myofibrils, in which you have the actin filament and the myosin head so close together there's no elastic stretch like a rubber band, and there's no stretching factor within these myofibrils, so when you release it, there's no elastic recoil that's going to help generate an increased contractility of the left ventricle, and therefore you can have a decreased cardiac output, and that can be shown here in the Frank-Starling curve, in which the preload or the volume within the left ventricle during end diastole is very low because the patient is hypovolemic, and so therefore he's going to have a decreased cardiac output, opposed to if you were to increase the volume within the left ventricle and compare that to the increased cardiac output. This patient, because they're under-resuscitated as far as volume or intravascular volume, they're going to have a decreased cardiac output. And a clinical example is if you had a patient who was hypovolemic, or you had a trauma patient who's having massive hemorrhage, and they're bleeding a lot, they have a decreased venous return, and ultimately a decreased left ventricular end diastolic volume, in which they're going to have a decreased cardiac output, which would probably be represented by a decreased mean arterial pressure. Their blood pressure may be decreased, and as a compensation, they're going to vasoconstrict and increase their afterload or their systemic vascular resistance, ultimately to try to increase the cardiac output. Now, if we were to see the same patient now adequately fluid resuscitated, and we can see that the patient has optimal left ventricular end diastolic volume, in which there's optimal stretch of the myofibrils, in which the actin filament and the myosin head now has a stretch factor, and when they contract, it's going to be like a released, stretched rubber band, having that elastic recoiling effect that increases the effect on contractility. And as we saw here, the patient's going to have an optimal cardiac output. And we can see here with an adequate contractile left ventricle, and you're going to have optimal cardiac output, and the heart's going to be able to perfuse all the vital organs adequately. And the last clinical example is if you have a patient that has an increased left ventricular end diastolic volume, there's such an overstretch between the actin filament and the myosin head that they actually are not able to make adequate contact to create the contractile or the increased contractility force or the elastic recoiling effect that contributes to an increased cardiac output. So you can see that their left ventricle is over fluid. It's a fluid overload in which the left ventricle is overstretched, and the myofibrils, the actin filament and the myosin head, are not able to make adequate contact to generate increased or an optimal cardiac output. And in fact, if you look at the Frank-Starling curve, they're all the way over here past the peak. So you had an optimal preload, which we just described, that gave us an optimal cardiac output. But as you increase the volume, the cardiac output tends to decline because of the overstretch that takes place within the left ventricle. And certain things take place, and we can illustrate this by saying as you increase the left ventricular end diastolic volume, there tends to be an increased hydrostatic force which generates increased pressure from the left ventricle, creates a back pressure in the left atrium, and therefore the blood that's returning back from the pulmonary veins tends to backflow into the lungs and creates pulmonary edema, in which you have a decreased cardiac output. You may have a patient that desaturates because you start to have pulmonary edema, fluid within the lungs, and in fact you may induce myocardial ischemia because as you increase this volume, you also increase the left ventricular end diastolic pressure, which tends to collapse the subendocardial vessels and decrease the blood flow through the coronary arteries. And that can be illustrated here as pulmonary edema because of fluid overload, and you have a preload that's too high, and it may cause pulmonary edema and myocardial ischemia. In the next lecture, we'll talk about afterload and how does afterload affect the cardiac function.